warm. I had to get an extra jacket because it's a little bit chilly in here. But it gives me great pleasure, ladies and gentlemen, to introduce to you a trial update by Ultragenyx. Let's give a round of applause, ladies and gentlemen, for Dr. Diva de Leon Crutchlow.
Thank you. Thank you. The applause helped warm us up. So thank you for the opportunity to give you an update about the results of this pivotal phase 3 double-blind placebo-controlled trial of DTX401 for the treatment of Glycogen Storage Disease Type 1A. I want to first say that I'm here representing the whole investigative team and the families that made this trial possible. So thank you to all of you that participated. I'm from the Children's Hospital of Philadelphia and the chief of the Division of Endocrinology and Diabetes there, and I treat all children with hypoglycemia disorders, including glycogen storage disease. These are my disclosures. I'm the principal investigator in the clinical trials sponsored by Ultragenyx at the Children's Hospital of Philadelphia, and I also have received consulting fees from Ultragenyx. As I mentioned before, this study was a multi-center study, so there were many investigators that participated, and we also want to acknowledge the study participants and their families. This is what I would like to cover today. We'll talk a little bit about the pathophysiology of GSD type 1A, in case there are people in the audience that are not that familiar with the condition. We'll talk about how the study was designed, what the results of the trial were, and also review a little bit of the safety data from this study. A lot of the graphics that I'm going to present are kind of very complex, so I will try to point out to the important points that I want to make with every figure, but at the end we will have some time to go over your questions. Just to center the discussion, in GSD type 1A, deficiency of glucose 6-phosphatase prevents the conversion of glucose 6-phosphate to glucose in the liver. And as a result, we are unable to produce glucose during periods where we're fasting. So in this picture of the liver, what I try to illustrate is what are the consequences of the deficiency of this enzyme. The main consequence is obviously hypoglycemia because the liver is unable to release glucose from the fasting mechanisms that are in place to maintain normal glucose during fasting. So from gluconeogenesis or the formation of new glucose and from glycogenolysis of the breakdown of glycogen. But there are other consequences that result from the deficiency of these enzymes. One is that the liver makes excessive lactate, excessive triglycerides, and uric acid. So the clinical features of glycogen storage disease type 1A are then hypoglycemia associated with low ketones, which is significant because ketones are the other metabolic fuel that your brain can use as a source of energy. So in glycogen storage disease type 1A, you have low glucose and low ketones, so the brain is really deficient on metabolic fuels. In addition, there is the lactic acidemia, high triglyceridemia, and high uric acids. And typically, children present within the first 6 months of life with failure to thrive and a big abdomen due to the enlarged liver. There are long-term complications that we screen for, as you heard earlier. We look for hepatic tumors, kidney disease, metabolic bone disease, and obesity is usually a long-term complication of the treatment that we use. So this DTX401 is an investigational gene therapy for GSD type 1A. So in this case, the therapy is delivered through a viral vector, AAV8, and the gene that is missing, glucose 6-phosphatase, is inside this vector. And in the case of DTX401, the gene has the same regulatory mechanisms to activate the enzyme as it is naturally. The first study that was done was a phase 1/2 global open-label safety and dose-finding trial that was conducted in 12 adults. And this is just a summary of the results from that open-label study. There were substantial reductions in cornstarch requirements that have been sustained for more than 5 years. So 69% reduction in the daily amount of cornstarch that these participants were taking. And the number of doses of cornstarch daily were reduced from 6.2 to 3.7. Because of the reduction of cornstarch, participants were able to shift towards a more balanced food-based diet. And the glycemic stability was maintained in the long term, and this therapy was well tolerated with an acceptable and manageable safety profile. So this study was very important because it determined what dose could be used in the phase 3, and the study design was informed by what was learned from this early phase study. So this is a complex slide that goes over how this phase 3 trial was conducted. First, the participants were 8 years and older with confirmed glycogen storage disease type 1A, either by molecular genetic testing or by measuring the enzyme activity in the liver. It was very important that these individuals have no evidence of having previously been exposed to this virus, so AAV8, and this virus occurs naturally, so some of us may have been exposed and we have antibodies. So before participating in this study, people were tested for the presence of antibodies against this virus. And patients with significant liver disease were not able to participate in this study. So the study had several different parts. The first part was a screening period where participants were, their cornstarch therapy was optimized during this period of time. And after the screening period, subjects were randomized 1-to-1 to either receive DTX401, and 21 participants were randomized to this treatment, or were randomized to receive placebo. And you can see the number of participants that received DTX401 or placebo. The first 48 weeks of the study were double-blinded, so the investigators and the participants did not know what therapy they had received. And at week 48 is when the results of the trial were evaluated. So the primary endpoint, this is the main thing that was measured as to evaluate the efficacy of the investigational drug, was the percent change from baseline to week 48 in the daily cornstarch intake for those that received DTX401 versus those that had received placebo. The secondary endpoints that were measured include the change from baseline to this week 48 in the number of total daily doses of cornstarch, the change from baseline to week 48 in the percentage of glucose values that were in the hypoglycemic range, and also patient-reported outcomes as the patient global impression of change that was assessed at this week 48. Then what happens at that time, the end of week 48, is that those subjects that had received placebo in the first part of the trial receive now DTX401, and the blinded period continued during another 48 weeks. At the end of this week 96, then the double-blind period ended, and there was an open-label extended period where participants were monitored until the end of the study, which was at week 144. At the end of the study, participants were invited then to enroll in a disease monitoring program that would follow them for at least 10 years. This is how the baseline characteristics of the participants in the trial. You can see that the mean age was about 20 years of age for both those that received placebo and those that received DTX401. There was a similar number of participants that were in the younger age, between 8 and 17 years of age in both groups. Similar number of males and females, and you can see the amount of cornstarch that they were receiving at baseline, which is very typical of patients with GSD type 1. And this cornstarch was administered in about 5 doses every day. So this is how the study participants look at baseline. This figure depicts the changes in cornstarch during this study period for those that received placebo in green here and those that received DTX401. So I first want you to look just at this part of the graph, which is the initial placebo-controlled part of the trial, to see, just very clearly those that received placebo, there was not a lot of change in the amount of cornstarch that they were receiving at the end of that week 48 compared to what they were receiving at baseline, in contrast to those that received DTX401, which had a significant reduction in the amount of cornstarch that they were receiving compared to those with placebo. Then at this point is when those that had received placebo received DTX401, and you can see what happened to their amount of cornstarch that they require once they receive the active treatment. And then this was sustained during the whole duration of the trial. Prior to participating in this study, participants were asked what would be a meaningful reduction in cornstarch intake, and the answer was about 45%. So at the end of the trial, this was achieved in the trial. So the mean percentage change in cornstarch at the last follow-up of the trial was 58% for those that initially received DTX401 and 56% of those that received DTX401 in the crossover period. Now, this is the total amount of cornstarch. There was also an evaluation of how many doses of cornstarch these individuals received as a result of participation in the trial, and also the doses that were received during the nighttime. So again, at baseline, there was a comparable amount of doses of cornstarch that people in both groups were receiving. And you can see that in average, the number of nighttime cornstarch doses was about 1.7. By week 48, those that have received DTX401 have a significant reduction in the number of cornstarch doses compared to those in the placebo group, and also a reduction in the number of nighttime cornstarch doses compared to the placebo group. By the end of week 48, 50% of subjects that received the active treatment, DTX401, had eliminated at least one or more nighttime doses of cornstarch, while only 7% of those that received placebo were able to reduce at least one dose at nighttime. So by week 144, 40% of those that initially received placebo and then received DTX401, and 33% of those that received DTX401 at the beginning, who had reported using cornstarch at night at baseline, stopped taking nighttime cornstarch completely. Of course, a very important aspect of this is that you're taking less cornstarch, you're taking less cornstarch at nighttime. What's happening with the glucose levels? And that's what's shown here. In purple is the reduction of cornstarch that I showed you before. And in the columns, the different shades represent the amount of time that people maintain glucose levels in certain ranges. So as those that were treated with DTX401 had reductions in the cornstarch, the amount of time that their glucoses were in the range of 70 to 120, which is the optimal glucose range, increased over time. And similarly, once the placebo group received DTX401, the cornstarch reduction was in association with spending more time in the euglycemic range. And during all this time, there were low rates of hypoglycemia that were maintained despite the reductions in cornstarch intake. Now, as part of the trial, another thing that was evaluated was how long could subjects maintain normal glucose during a fasting period. And this is a busy table, but I want you to look at this last row here, where is the duration of time in hypoglycemia during a fast according to the amount of cornstarch that the subjects receive prior to starting the fasting period. You can see this is the baseline, and this is the difference between the DTX401 and the placebo group by week 48. And then by week 96, which was the last fasting test that was done, both groups had a longer period of fast normalized for the cornstarch they were taking compared to baseline. Now, a very important aspect of when we do a clinical trial is also to incorporate the perception of those participants on how things have changed for them as when they participate in the trial. So that's what's shown here. In the upper part is the placebo group, and then the placebo group once they receive DTX401. And as you can see, in the placebo group by week 48, they reported a 52% improvement in quality of life, and that increased to 95% and 94% by week 144 once they had received DTX401. And for the group that received DTX401 from the beginning, by week 48, the quality of life had reported to be improved by 79%, 83% by week 96, and 82% by week 144. This is a summary of the safety profile of the treatment. The important identified risks are hepatic reactions, and these are known risks that follow the administration of similar gene therapies with AAV vectors. The most frequently reported treatment emergent adverse event was elevation of liver enzymes, but most of these liver enzyme elevation were not serious, transient, and were managed with oral corticosteroids. There were also infusion-related reactions. These are reactions to the treatment itself when the treatment is administered as an intravenous infusion. There were 2 grade 3 serious adverse events related to the infusion that resulted in the termination of the infusion, but these reactions result with treatment, and they were not long-term clinical sequelae. As a result of these reactions, the protocol was modified to lengthen the duration of the infusion and also to administer some medications to ameliorate the reactions. And after these modifications were implemented, there were no other reactions observed. Now, there are a number of important potential risks associated with the administration of gene therapy, and none of these were observed during the course of this trial, including no evidence of insertional mutagenesis or malignancies or thrombotic microangiopathy. There are other potential risks that were observed during the trial, including elevation of triglyceride levels, Most of these were non-serious, mild, or moderate in severity. There were 3 serious adverse events related to elevation of triglycerides. And importantly, none of these cases with elevated triglycerides had any evidence of pancreatitis, which is one of the consequences of elevated triglycerides that we screen for, or other clinical sequelae. This is a little bit more information related to the effects observed in terms of therapies needed for elevated triglycerides. So at baseline, 7 participants that were on the placebo group were using lipid-modifying agents, and 8 participants in the DTX401 group. At the follow-up period in week 48 and week 144, 4 participants in the DTX401 were receiving lipid-modifying agents, and 10 participants in the DTX401 group. There were not observed changes in lactate, alanine, and uric acid, which were measured before the fasting period. In addition to this trial that was conducted in multiple sites around the world, there's a study conducted in Japan that included 3 participants. That this was open label, so all 3 participants received the therapy. There was no placebo arm in this study in Japan. And the unique thing that you have to know about these subjects in Japan is that they all had this very specific mutation. In this case, in the 3 participants that took part of this study, all of them were able to eliminate the use of cornstarch completely by week 36, with increase in the quality of life measures, and also reduction in hypoglycemia in these groups without serious adverse events. So to conclude, a single dose of DTX401 resulted in a statistically significant and clinical meaningful cornstarch reduction that was sustained to the duration of the trial at week 144. There was not only reduction in the total amount of cornstarch, but also the dose frequency, the needed doses of cornstarch during the nighttime as well, while maintaining low levels of hypoglycemia with an increase of the time that subjects spend in the euglycemic range, and also reported improved quality of life during this trial. Obviously, we need to continue monitoring the nutritional intake, glycemic control, and metabolic control after administration of DTX401, but overall DTX401 was well tolerated with an acceptable safety profile, and subjects are now being screened and monitored as part of this disease monitoring program that will continue for more than 10 years, at least 10 years. Thank you for listening, and I'll be happy to answer any questions. Yes.
I'm coming to you, hang on.
Was there a specific diet that was required for all of the participants in addition to the cornstarch reduction?
Yeah, so subjects receive dietary management as the usual dietary management that they receive, and what the nutritionists were working with the participants to make sure that as the amount of cornstarch was reduced, carbohydrates were introduced in the diet, and that they maintain, appropriate nutritional intake. So that was definitely part of the management as it would be outside of the trial. But there was no dictated, that everybody has to follow the same diet. It was really tailored to the particular patient.
Can you elaborate a little bit more on the immunosuppressant protocol that you had? Did
Yes.
you start that initially and with the placebo?
Yeah, so I don't have all the details here, but basically, as a result of what was learned from the phase 1/2 trial, the approach in that trial, if I remember correctly, was to introduce steroids, if there was evidence of elevation of liver enzymes. In this case, everybody received a course of oral corticosteroids. Those that receive the placebo receive a placebo oral corticosteroids, and those that receive DTX401 were on oral corticosteroids. So there was no unblinding there, if that was your question.
What was the long-term care after the trial?
Tell me again, sorry.
What was the long-term care after the trial?
Yeah, so as I said, participants were invited to enroll in the disease monitoring program, but their baseline care for their GSD continued to be provided by the primary team. So, I can tell you what I'm doing with my patients is not different. Same kind of monitoring and same recommendations for monitoring glucose and labs and ultrasounds. Other questions? Well, thank you for listening.
Thank you very much for speaking.